Welcome to the Global Health Tuesday webinar. My name is Jim Conway. I'm one of the Associate Directors for the UW Global Health Institute, and really pleased to be able to introduce our speaker this afternoon. I'm also one of the directors of programs over at the School of Medicine and Global Health. I'm going to ask you guys to can you please mute your. Thanks. If people can just keep their phones muted, thanks. So today is Global Health Tuesday, and this is a seminar series where we host researchers and practitioners from UW-Madison and from across the world. And these speakers really showcase the complexity of global health challenges and the many kinds of expertise needed to address them. And by sharing their experiences with the campus and Madison communities, our guests provide insights into global health, encourage conversation, and help connect colleagues both locally and globally. The series will resume again for the fall on a more regular basis on September 28th, when Anna Kalberchik from Johns Hopkins is going to discuss white saviorism, decolonizing global health, and what that means for training and education. We'll have more information on our website as we receive it, but mark that one on September 28th. Should be really very interesting. A couple of other housekeeping items. As you noted, the seminar is being recorded. If you have questions, please put them in the chat, and we'll have time at the end for Q&A. But Dr. Zafar has been kind enough to offer to take questions during the chat, during the seminar as well. So if people have questions or comments that they want to offer, please put those into the chat and we'll be monitoring those. So without further ado, today I've got the great pleasure of welcoming Dr. Syed Nabeel Zafar, who is one of our newer and really more interesting faculty here at the UW. He's an assistant professor in the Division of Surgical Oncology with a Bachelor of Medicine and a Bachelor of Surgery from Aga Khan University Medical College, as well as a Master of Public Health from Harvard's T.H. Chan School of Public Health. He did a general surgery residency at Howard University and then completed a complex surgical oncology fellowship at MD Anderson Cancer Center. He's been working with colleagues to establish a global oncology group. I think as many people are aware, in global health, the focus has really been on communicable diseases for so many years. And there's really a need for more and more attention to non-communicable diseases with our country partners in less resourced areas. And so Dr. Zafar and his group have really been trying to figure out ways to explore the background challenges related to global oncology, the current status of care, what initiatives from national and international organizations might be able to assist, and most importantly, in our minds, to develop this global oncology program here at UW-Madison. So without further ado, happy to have him here, and I'll turn it over to you, Nabeel, for your talk.
Thank you very much, Conway, and thank you to the Global Health Institute for hosting me. It truly is a pleasure to talk about something that's very near and dear to my heart. I'm going to share a screen, and if someone can give me the thumbs up to let me know that it is working. All right, great. Got a couple of thumbs up there. So I'm going to talk about global oncology today and how we can work together to address some of these disparities. There are some disclosures. One is it's a pretty long presentation, and I'm going to give a lot of information very quickly. So pay attention, I suppose. No financial disclosures. There's one graphic slide. Don't eat before that. Talk is not about solutions. I'm going to highlight a lot of problems. A lot of this is weighted towards low and middle income countries, and I'll define that. Although global, when I say global, I do mean truly the whole world, including more high income countries as well. A little bit of quick introduction. I know Dr. Conway did say some of this, but I grew up in Karachi, Pakistan, and spent much of my childhood in Northern Ireland. Came back to Pakistan and did most of my schooling there. Was in a family of doctors. I was doctor number 31 in that family. But the reason I say that is we went to a lot of rural areas throughout Pakistan to give medical care, and that's when I saw really the disparities in healthcare that got me interested in that. After med school in Karachi, I came to America. I spent a year in Boston doing a master's in public health and did my residency in the DC, Maryland area, and fellowships in Maryland and in Texas, and now I'm at Wisconsin here. So I'm doing GI surgical oncology, and I'm a health services researcher. An outline of my talk, I'm going to talk about a few definitions, a little bit about the burden of cancer care around the world. We'll talk about some disparities in outcomes and why these exist, some of the opportunities that we can intervene at, and what's going on at a national level and what we want to achieve here at UW. So when I say low and middle income countries, it's based on national income or GNI per capita. And the countries that are not blue here are the ones I'm talking about, as in low and middle income countries. As you can see, China comes in that category as well as an upper middle income country, mainly because it's GNI per capita. When I talk about the cancer control continuum, I'm talking about multiple things here, and we'll address these a few times in this talk. We'll talk about prevention, early detection, diagnosis, treatment, a little bit of survivorship and end of life care, and there's some cross-cutting issues. But when I say cancer control continuum, I mean all of that. Now, what is global health? I probably don't need to define much of that for this audience, and there's a lot of definition, nobody agrees on that. But in my mind, achieving health and health equity for all people around the world. And then global oncology is a branch of global health, which is focused on cancer. With that, I'll just give a little bit of a primer. We'll start with a regular patient or a person in America. We call him Joe, and he's just going to be an average Joe. He's 72 years old. And we'll talk about a patient from Pakistan, Yusuf, and we'll call him average Yusuf, and he's 67 years old. So average Joe, his story starts with, he got a screening colonoscopy as per schedule, and they found something in his colon that eventually he went multitude of testing, including CAT scans and PET scans and pathology and diagnosed multiple healthcare providers, and he was diagnosed with early stage cancer. He underwent robotic surgery. And then after that, he had some special molecular profiling done, and we came up with fancy targeted precision oncology treatments, and he got some chemotherapy after that. And after that, he underwent a lot of surveillance every 6 months to a year, which included testing and imaging. And he got a thumbs up from the doctor every year. And then 5 years later, he's still alive and kicking and very happy that we made it this far. Not a similar story for some average Yusuf in Pakistan or some other low and middle income country. Yusuf unfortunately noticed some blood in his stools, and he really didn't know what to do about that. So he kind of ignored it, did not seek care. Until one day at work, he fainted because of anemia and blood loss, and he got transfused and went back home. But eventually a friend of a friend who was a doctor told him that maybe he should get a colonoscopy done. And he got the colonoscopy done after some delays and was diagnosed with late stage cancer, also colon cancer. It was decided he needs surgery, so he went to NGOs, charity organizations, a lot of community support. They raised money and they got him the surgery he needed, which is great. He did suffer some infections post-op, but he did fine. And then we don't know what happened to him. He was lost to follow-up. No surveillance, nothing. Then one day out of the blue, 5 years later, he brings his friend to the doctor. And that's how we know that he's also alive and kicking and alive 5 years. So different pathways, but similar outcomes. That probably does not happen at all. The outcome's not going to be similar. I would say Yusuf did get healthcare, and he was pretty lucky in that setting to get a lot of the care he did. In America, average Joe was also pretty lucky. He got a lot of care. We know that there are a lot of disparities within America, and not everyone has access or gets the care they need in a high-income country, and certainly not within a low-middle-income country either. So when we talk about global oncology, I'm going to give you some numbers just to know why should we care about cancer care around the world. The long story short is that it's significant and it's increasing. 1 in 6 deaths around the world are due to cancer. 18 million cases in 2018, up to 30 million cases in 2040 is projected. In 2019, and this paper kind of changed a lot and put a lot of things in motion. This is a paper that comes out every few years about what are middle-aged people dying of around the world. And for the first time ever in high-income countries, cancer took over everything else. So in high-income countries, cancer is the #1 cause of death in middle-aged adults. And that's what changed. And overall, around the world, it's #2, but it's increasing. If you look at middle-income countries and low-income countries, it's right up there next to cardiovascular diseases, and very soon it will be the #1 cause of death around the world. If you look at countries, so this graph shows what rank cancer is as a leading cause of death, and essentially it shows that in most countries, which are the darker colors, it's either the number 1 or number 2 cause of death around the world. The economic burden is huge as well. We don't have great numbers for around the world, but in USA alone, economic cost is 1.16 trillion a year, and that's loss of productivity, household income, disability, healthcare costs, reduced quality of life. When we talk about cancers around the world, which cancers are we talking about? The top 3 in men are lung, prostate, and colon. Top 3 in women is breast, and you can see that big dot here. Breast dominates the rest, and it's colorectal and lung as well. But 1 in 5 people around the world will develop cancer before the age 75. I told you a little bit about the incidence of cancer, but mortality is a little bit different. Lung is still amongst the highest, then followed by colorectal, then stomach, then liver. Breast comes down in terms of mortality. But then you've got esophagus, pancreas, which are more lethal cancers as well. About 10 million deaths from cancer in 2018. If you look at where these cancers are happening, it's pretty clear. The dark blue are the higher numbers. So wherever it's the darker shades of blue is where cancer is happening. And if you remember the slide, low middle income countries, it's not low middle income countries. Most of the cancer is happening in high income countries. So why do I care so much about low and middle income countries? We'll see that in a little bit. But this is another graph showing the same thing. As your income level goes up, the incidence levels of cancers go up around the world. Most common cancers in men around the world does differ. In Northern America, Southern America, it's prostate cancer. In Europe, a lot of it is prostate cancer, probably because people do live longer in those countries. In India and Pakistan, it's lip and oral cavity. We'll come to that again. And Kaposi sarcoma dominates a larger part of Africa as well as liver cancers. Most common cancers in women. Now, this is interesting, right? Breast dominates the world, except for sub-Saharan Africa and other parts where cervical cancer is high. And we'll come back to that as well. And that's why a lot of the funding, a lot of the awareness, a lot of the talks is on breast cancer, because that clearly dominates the globe. Another issue is that cancer is rising. Almost every country in the world is seeing an increase in incidence of cancer. 127% in North America, 140%, 147% in Africa, 135% in Asia. So it's on the rise. And if we look at where it's rising the most, it's rising in low and middle income countries, much higher than it is in high income countries. And there's a lot of factors due to that. People are living longer, people have access to healthcare, but there might be environmental and genetic factors as well, or we're diagnosing them more. Just to give you some quick stats again, in 2018, 18 million had cancer and 10 million died. Every country has seen an increase in the cancer cases. By 2040, numbers are going to double. Cancer is number 1 or number 2 leading cause of death in 134 out of 183 countries. It is the cause of 30% of all premature deaths, and it's rapidly rising, mostly in low and middle income countries. But what if we look at the outcomes of cancer, and they're disparate. So in high income countries in America, the rates of mortality have been steadily decreasing with time in both men and women, which is great. And this decrease, we've seen about 20%, but in low middle income countries, it's been really meager, 5%. And like Dr. Conway said, we've been focusing a lot on infectious causes in low and middle income countries, and trauma and HIV and TB, typhoid, malaria. And cancer has really been neglected. A way to look at disparities is something called the mortality incidence ratio, so number of deaths per new cancer cases. So yeah, the high income countries have a lot of incidence of cancer, but what are the outcomes, and can we use that to compare the outcomes? And it kind of is a marker of how well the system is doing to manage cancer. So this is a project a couple of our Shapiro students this summer did, Shada and Dan, under the supervision of Tom Deal, one of our surgery residents here. And we calculated the mortality and incidence for about 35 or 37 cancers in 183 countries around the world from different data sources, and correlated that. And what we find here is, so the darker colors means that mortality to incidence ratio is higher. So of the cancers you get, you're more likely to die in these darker countries. So you can clearly see how cancer deaths are disproportionately higher in low middle income countries. It's the same disease, but you die more likely to die depending on where you are in the world. And that highlights huge disparity. This is some registry data from the Concord, which is a population-based registry. And you can see in America, for example, esophagus cancer, 5-year overall survival is 20 months, India is 4 months. Colon 65 versus 39, and so forth. 70% of deaths of cancer occur in low and middle income countries, so a huge burden. And it's, so basically what I'm telling you is that cancer is rapidly rising in low and middle income countries. Our outcomes are poor in low and middle income countries. So if you guys wanna type away in the chat about what the answer is to this question, so the number of people dying of cancer around the world, is that expected to decrease, stay the same, or increase? And I'll just pause for a second here. But as all MCQs go, the answer is C, right? So yeah, so and there are a lot of answers there. So yeah, it's increasing. This is high income countries in green and low and middle income countries in blue, and cancer deaths are just going up and up and up, and we have to do something to do something about it. And that's the whole point of global oncology. The big question is, why are outcomes worse? To understand what we could do, we need to understand what factors go there. And we went through some of this in this story between Joe and Yusuf, but we'll take a closer look at things across the cancer care continuum again, starting with prevention or early diagnosis, or in a simplistic way, I'll parse it up into 3 main things that to stop it from happening: etiology and primary prevention, detect it earlier, and then treat it in an effective and timely way, and then we'll have cancer control. Primary prevention, we know there are a bunch of causes for cancer, which range from environmental pollutants and radiation to genetics and smoking. And if you look at the proportion of cancer that could have occurred if say smoking did not happen, that's this number here in the right column. So tobacco is high up on the list, but you've got behavioral factors, infectious causes, environmental factors, and genetic factors as well. And I'll just give some examples of these as we move on. But tobacco, as you can see, the leading cause, 2.4 million deaths from cancer due to the use of tobacco products each year. And where are cigarettes being consumed? A lot in the Soviet Union and high-income countries. Not so much in low-middle countries yet, but it's growing there. If you look at the number of cigarettes used, consumption, it's going up in China, going down. These are 2 countries in Africa, South Africa and Egypt. You can see it goes up in Egypt, goes down in South Africa over time. That's because of more restrictions and policies, and then tobacco companies target low and middle income countries much more. UW now does have a Center for Tobacco Research and Intervention, and we've done a lot of work over many years on tobacco control. And so we have a lot of experience dealing with this here and in other countries as well. I will mention that local solutions, and I'm very curious to see how our cigarette or tobacco control policies would work in countries like Asia, where betel nut use is pretty rampant. The betel nut is a form of chewing tobacco that countries are addicted to. And if you look at this map again, the orange oral cavity cancers, where they're prevalent, is also where betel nut addiction is more prevalent as well. If you look at cancer attributable to infections, we've got the 2 big ones are HPV and H. pylori. But let's talk about human papillomavirus a little bit in detail. And Hep C, hepatitis are also a huge burden as well. But if we look at cancers where infectious cancers happen, or cancers attributed to infectious diseases, it's low-income countries as well. HPV infections, these darker red, you can see where those are happening. A lot of parts of Africa, very, very less in high-income countries. And that correlates very well. I'm going to just shift through these slides again and again. Correlates pretty well with cervical cancer rates around the world. Cervical cancer is unique, that it is quite a preventable cancer. We have a vaccine, we have screening. I guess you guys know where I'm going with this. But if you look at vaccination rates around the country or around the world, there unfortunately there's much work to do with HPV vaccine in developing countries or low and middle income countries of the world. I will highlight one of our researchers here, Megan Fitzpatrick. She's in the Department of Pathology, joined about over a year ago, and she's done a fair amount of work in Zimbabwe, which does have a high rate of cancer, and cancer is the most common cause of death there. And her work, and you can talk to her more about it, how she's using community-based interventions for HPV screening and vaccination. And then our very own Howard Bailey and a lot of researchers at the Carbone Cancer Center have been working on HPV vaccination globally for many, many years. So we have a lot of institutional strength in that. Just a reminder slide here. So we've got behavioral factors that can be prevented in tobacco control strategies, alcohol consumption, physical activity, vaccination, and a lot of cancers can be addressed by these preventive measures. Let's move on to early detection. Early detection it basically encompasses two things. One is early diagnosis for symptomatic cases and screening for asymptomatic cases. Sorry, I was going to warn you about that graphic slide, but that is the graphic slide. When I was growing up in Pakistan, this is what I saw, and I never wanted to be a surgical oncologist at all, because that's what I saw, and all the operations we did were palliative operations with really no hope, and it was just a depressing field altogether. If you look at the data, then this is the proportion of surgery being done for palliative intent versus curative intent. So in low middle countries, 70% of cancer surgery is palliative compared to just 12% in high income countries. So there's a huge difference there. If you look at case fatality, that's the number of people dying from breast cancer, cervical cancer, testicular cancer, matched for incidence and stage. The fatality is much higher in low and middle income countries than high income countries for almost every single cancer. We have to downstage the tumor if we want to give people a chance of living long lives from these tumors. We have to downstage the tumor. So one of the big things is catching it early. Now I'm going to ask this, and you can type away. What do you all think of screening? Is screening great? Should we do this, or is that the next best thing? We have a few screening options here: Pap smear, HPV, visual exams, colonoscopy, mammography, genetic testing. This is not an MCQ, sorry, but whenever I talk about global oncology, the most common thing or most common solution I get from people is we just need to implement screening around the world. That's it. We do screening, and as you can see, we detect cancer earlier, and we'll solve the problem. But does screening that applies in high income country, does it apply in low and middle income country settings? Let's take an example of breast cancer and mammography. It's been around for a while, and we've perfected the technique over the years. And we've seen a definite decline in mortality from breast cancer just because of mammography or screening, which is great. And a lot of paper came out, a lot of talk came out, and a lot of low and middle income countries try to implement screening programs across the world. It really was the next best thing. You can buy one, get one free deals as well. But for screening, and we put mammograms on buses everywhere in Asia and Africa and try to do this. But for screening to be effective, and I'll just go through this pathway a little bit, you have to invite a targeted population, say that's 1 million people, and then you apply the screening test to asymptomatic people that may or may not want to come for that. And then you notify them of the results, and then you make sure they follow up, and then you have to go through more diagnostic evaluation to get the positive results, and then you have to treat the cancer. And that's what makes screening effective. If at the end you're able to treat it as well. But population screening, unfortunately, in low and middle countries has not been effective. We've targeted incorrect populations, we've misallocated resources, and we've had low participation rates. There was a huge debate about this, but it's pretty much settled by now. It's just not working that well for all cancers. For example, 55% of low middle income countries, 19% of middle income countries offered cervical screening, but they don't have access to surgery or radiation. So what do you do about those cancers you do diagnose? Or 60% didn't have pathology, so you see something, a lesion that needs diagnosis, and you can't do that. For screening to be effective, you have to cover a substantial portion of the population. The tests have to be accurate for your population. You have to have adequate follow-up, diagnostic verification, timely and effective treatment, and quality assessment of these programs. And you have to ensure equal access. You have to have a robust infrastructure. So that's a typical example of putting the cart before the horse. You take the screening program and you put it in countries without the infrastructure to deal with that, and you know, the cart cannot move the horse forward, and it causes harm. It causes anxiety to individuals. They undergo a lot of testing with no treatment options available to them. They have to pay out of pocket for screening tests often, or for the diagnostics. Healthcare system, there's diversion of resources that could have been used in a more effective way. And what do you do about false positive tests or overdiagnosis, cancers that may not have been apparent in that person's lifetime? And we see that a lot. For example, prostate cancer is a big example of that. We talked about the expenditure there. So how do we detect it early? And an effective strategy is early diagnosis. So if this is the pathway of symptom onset, screening is on this side before you try to detect it before you get invasive cancer. And then once you have symptoms, that's what we call early diagnosis. So instead of targeting like millions of people, you can target only those people with have symptoms. There are certain downsides to it, but if we focus on awareness of symptoms, rapid clinical and pathological assessment and referral, that can really make a difference. In fact, early diagnosis is probably the most effective public health measure we could in cancer. And 3 steps we talked about: awareness, clinical evaluation, access to treatment. There was a study, meta-analysis that was done, and we saw that the longest delay is here in this part, step 1, getting care. As in Yusuf's case, he saw blood in his stool, but he didn't do anything about it. So raising awareness of symptoms and when to seek help and creating that referral pattern can definitely have a huge impact. Unfortunately, very few countries have guidelines for early diagnosis of cancer, from the primary care setting to getting to a referral facility for every kind of cancer that we study. But there are some good examples. This is a recently published paper or endeavor done in Mexico. It's called the Alerta Rosa program, which basically they did early diagnosis. They didn't try to screen for breast cancer at a population level. They did a lot of media campaigns, and they set up call centers through Facebook and social media. Patients, anyone could reach out to them at any time. And then step 2 was rapid diagnosis and then referral to facilities to treat them. And what they saw was that they diagnosed 59% of tumors in early stages. And we know from studies before that in low and middle countries, about 70 to 80% tumors present late stages. So if they were diagnosing 59% early stages, that's a huge win. And then they were able to start treatment within 30 days on average. That's it. Those are some examples of how things can be successful. Now, diagnosis is another big challenge. More than 60% of low-income countries lack basic pathology to diagnose cancer. When it is available, it's discordant in at least 40% of the time. If you look at number of pathologists to population, the red is 1 pathologist per 5 million people, as opposed to 1 pathologist per 15,000 population in the UK or in the US. These countries, in a lot of countries, just don't have a pathologist either. We're going to see a lot of examples of the workforce. If we switch gears and go to cancer treatments, general principles: you need timely, coordinated care that's affordable, comprehensive, and provided by trained professionals. But do we have that? Probably not. If you look at countries that reported public sector availability of services, cancer or a cancer referral facility or a cancer tertiary care center, it's about 3.3 centers per 10,000 people in high-income countries, and as low as 0.8 for 10,000 people in low-income countries. We don't have enough facilities available. This was a study done that followed patients with breast cancer that presented to a tertiary care hospital in different parts of Africa, and they found that 38% women did not receive treatment of their breast cancer up to 1 year of presentation. So these are people who actually made it to the hospital, but were for some reason or the other, and a lot of that is cost and faith and access to care, that they were not ever treated. Now, when I talk about treatment, I'm talking about surgery, chemotherapy, radiotherapy, and then we've got palliative and supportive care options. For all of these, you need a workforce, you need facilities and infrastructure, and you do need to look at the quality and outcomes for each aspect. And I'll briefly go over some of the main parts here. If you look at the availability of radiotherapy machines per million population, the reds have no radiotherapy machines. The blues have more than 5 machines. But you can see there's clearly a lack. 9 out of 10 people in low-income countries cannot access radiotherapy. In Africa, actually 40 countries have no radiotherapy facilities at all. And if you look at number of radiotherapy, or if you look at radiation therapy by income, you can see that high-income countries have more radiation therapy infrastructure, while low-income countries are pretty flat line down here. The Lancet Commission on Radiation Oncology suggested that we can have economic benefits up to $365 billion by creating radiotherapy infrastructure in low and middle income countries. Chemotherapy, similar thing. Number of patients requiring first dose chemotherapy is about 10 million right now, and estimated to be 15 million by 2040. So how do 10 million people around the world get chemotherapy when 63% of them are in low and middle income countries? And who administers this chemotherapy? If you look at the number of oncologists available, it's a similar story. In countries like America, there's 1 oncologist per less than 150 new patients per year, versus some parts of Africa and Asia where a single oncologist has to see 2,000 or 3,000 patients per year. And a lot of places also don't have trained oncologists. Chemotherapy medications are also unavailable, unaffordable by the majority populations. So I'm a surgeon, and I'll have more slides on surgery. Sorry about that, but surgery is essential to cancer care. It can be preventive, diagnostic, curative, palliative, and these are the common cancers that are around the world that are amenable to surgical intervention. In short, 80% of cancer patients need surgery. And there are estimates by 2030, 17 million cancer surgeries will be needed, and 10 million of these will be needed in low and middle income countries. So do we have the infrastructure to support surgical care and complex cancer surgical care in the low and middle income countries? We're not there yet either. In fact, less than 5% of patients in LMICs have access to safe, affordable, timely cancer surgical care. We did a study, and this is a medical student I worked with at the Afghan University. And we looked at the number of patients that need cancer surgery around the world, looking at different data sources. And you can see, just like incidence, the people who need surgery are in high-income countries, and about 9 million surgeries is what we estimated. But if you look at number of people who need cancer surgery per surgeon available, the graph reverses. So each surgeon needs to do more surgeries in low and middle income countries. In fact, 10 times more cancer patient to surgeon ratio in low and middle income countries and high income countries. It just shows a huge disparity in the workforce, disproportionate to the amount of cancer that's there. Economic effects of not providing surgery is huge. The light blue is cancers, and as you can see, that's just increasing as the years go by. Fortunately, the University of Wisconsin and our Department of Surgery has a pretty robust global surgery program that is working towards addressing these issues of access to surgical care, surgical education, and quality improvement in surgical care around the world. This is led by Dr. Girma Tefera, who is also a faculty of the Global Health Institute. So we are already working towards that. What about outcomes after cancer surgery? This is a study we also participated in, multi-center, multinational, 428 hospitals across 82 countries in the world, looking at breast, stomach, and colon cancers. And what we see, and this was just published earlier this year, is that mortality is higher in low and middle income countries. These are the other graphs. Complications with data was a little bit iffy, but the real kicker was down here. Patients who do get complications are much more likely to die in low and middle income countries. So the whole concept of failure to rescue, and that's just a surrogate marker of how robust the institution or healthcare system is when things break down. If you look at palliative care, only 14% of the world population has access to palliative care services. These graphs all look the same and probably not mind-numbing by the end. This I always find interesting, morphine availability in terms of percentage of people who need it and the availability of morphine. Obviously, Canada and USA, Australia, we have much more morphine than we need, while other countries do not. So I do highlight a lot of problems here. We are on time, but what can we do about it? All right, that's our cue for a stretch break. I'm gonna pause a little bit so everyone can stretch and I can breathe and drink my tea. I'll give you some examples of how to stretch while you're zooming. All right, so we talked about primary prevention strategies, tobacco control, vaccination, and what some of the great work that we're doing at UW on that, and some early detection work. But there's a few other important things that I did want to talk about, and number one is data. What you don't count doesn't count. We do need accurate data, and only 1 in 4 countries across the world have high quality statistics to inform decision makings or inform what cancer is being done where. A lot of the estimates and maps I showed you were just that. They were just estimates based on not so great data. And there are multiple types of data that we can use to further our cause or to get cancer control done. There's population surveys, vaccine registries, screening registries that can really look at attributable risk of cancer. Then you've got prevalence of cancers by type, by stage, and that will come from population-based cancer registries. And then you've got what the effects of cancer are from the vital statistics. So disability adjusted life years, or how many people are dying, or what are the economic costs. And this data is really important for policy. But unfortunately, registry data is sparse. This is another paper we did with the same medical student in Pakistan, and it just shows that the lack of the dark or the red are countries with national registries, which is what everyone should aspire to. But the light yellow and whites are no data or no really meaningful registries. And so how do we inform? How do we even know what's going on in the country? If you look at the population covered in North America, 95% of the population is covered by a registry, compared to only 2% of the population in Africa, 6% in Asia, 8% in Latin America. Europe is interesting because, a lot of Eastern Europe is low and middle income country, and within those countries, if you see the countries that have robust registries have better cancer outcomes, even though they belong to the same income category. Just goes to show how important the data is. And I was going to ask this question, but most people think registries are very expensive to do, but this has been studied. You need specific types of information. You don't need 39 variables, 50 variables, and the cost of maintaining a registry in India was less than 1 cent per person or per population, 1 cent in Kampala, 3 cents in Nairobi. You can easily see how governments can add a tax to cigarettes or tobacco products and fund registries if we can advocate for that and build that infrastructure to do that. In a sense, it can be done. In fact, cancer informatics or research capacity building in low-income countries, I believe, is an essential component of global cancer control, and I think it's one of the initial steps we need to take. Advocacy is another big thing, and I won't go too much into that, but countries that have a national cancer control policy, action plan, or strategy are more likely to have population-based registries, effective screening programs, referral programs, public sector access to cancer treatments. if you look at this mortality incidence ratio data that Tom, Shada, and Dan had come up with, again, they correlated that with life expectancy index. And as you can see, as within the same income category, like green dots are all low income categories, orange is all low, middle, upper middle. But you can see the spread here. So even within a low income category group, if the life expectancy is higher, you have better outcomes from breast cancer. Life expectancy is really a surrogate of how strong the healthcare system is in general. And that's not just income of the country. So it's not just money or just GNI or gross domestic product we need. I'm going to move gears here a little bit again to education and training. And this is one of my favorite studies. I didn't do it, I just read it. But it looks about operative volume in different places in Africa, particularly Uganda. And they looked at what surgeries are being done where. But what I found interesting was the operative volume was not correlated by the availability of electricity, oxygen, light source, suture, gloves, all the excuses we come up with saying that surgery is so expensive and luxurious, we cannot provide it. But the operative volume was directly correlated with the number of surgeons and the number of healthcare workers. So it just goes to say you train people and they'll figure out how to get the rest. They'll figure out how to get an operating room with all the equipment that's needed and get it done. It's going to be the same for oncologists, pathologists. You train them and they'll figure out the rest. We did some work on laparoscopic surgery in Pakistan and Mongolia, and we saw the same. You train surgeons how to do laparoscopic surgery, and then they figure it out and get laparoscopic equipment where none existed. So there's organizations working on curriculums for surgical oncology, for gynecological oncology, or medical oncology. And those are some things that we can do. I do want to highlight the International Gynecological Cancer Society. They have they've been doing this for a year, for many years, and they train a few fellows per site, and they match them to institutions near their low middle income country and also in high income countries. And they have a presence in different parts of the world. So fellows rotate and faculty rotate, and just increase training throughout the globe for gynecological cancers, which, as we saw, is a huge problem as well. Collaborations is another huge thing that we can do fairly or relatively easier. Project ECHO is extension for community healthcare outcomes, and this came out of New Mexico when we're looking at how to treat hepatitis in the state, and he started doing telemedicine essentially to talk to primary care doctors about how to provide care, and we look at outcomes, and they're similar to as if a patient had come to University of New Mexico or not. Now that has been expanded to almost every kind of chronic disease, and there's a lot of video conferencing we do here as well in Wisconsin with our neighbor institutions, but this can be done and it's being done around the world for cancer multidisciplinary conferences, or teaching how to, or helping providers simulate radiation therapy or provide oncology or chemotherapy and their side effects and case discussions. And these are great platforms, and it's just taken off, and they have a huge presence around the world in terms of programs and hubs. Collaborative data collection is another great example, and some of our surgery residents here, Taylor, Sasha, Patrick, and James participated in this study where I have to mention COVID, unfortunately, but it did take over most of our lives. So we did study cancer and how that affects surgery. So 447 hospitals in 55 countries participated, including our hospital here, to inform the world of what to do with the cancer patients for elective operations. Nurses Juma recently left us, but she did this study while she was here, which is called the Ola COVID project in Latin America. Also during COVID, basically started a social media chain, which kind of snowballed across Latin America and connected her to over 1,000 oncology providers. And they kind of asked, what are you doing with COVID patients? And it was a self-support group. So a lot of education, training, and meaningful data. So I would say that the two most important studies in oncology and surgical oncology, which were multinational collaborations, and UW had a huge participation in both of them. Innovation is a is key. We're doing things differently. We're doing things in resource constrained environments. So innovation is a huge aspect of what we're going to do. On the left here is a solar-based PCR system to help diagnose Kaposi sarcoma in Uganda. On the right is a high-resolution microendoscopy for esophageal cancer. These can be cheaper, more point-of-care contacts. Mobile health, it has huge potential, and a lot of low and middle country global health is around mobile health, and we can use that for cancer care. If you look at pathology, remember we don't have enough pathologists, but the whole concept of digital pathology and artificial intelligence and can completely support the lack of healthcare providers until we train them up. Artificial intelligence, in fact, has a huge role in global health, and it's growing. And here are just some examples which I'll kind of quickly go over, but our own institution is so strong in artificial intelligence and radiology, and we've created these machine learning algorithms to help read mammograms, which wouldn't replace a radiologist, but would significantly decrease the burden of images they have to read. And why can we not translate things we learned in Wisconsin to the rest of the world? You can totally imagine how that can be done. I'll give you another example of high resolution microendoscopy for cervical cancer screening. And so this is a high resolution microendoscope with an artificial intelligence based algorithm to read it. So not only are you seeing the patient and testing them, but you're getting a diagnosis at the same time, and you can offer treatments in terms of ablation at the same time. So point of care testing. So this was a group from MD Anderson and the Rice University that developed this, and then they made it into a bus and went to rural areas of Mozambique and Brazil and tested this out, and it worked great. And then it worked so great that they've been using it in the Rio Grande Valley in Texas. So this is a great example of reverse engineering or what Texas can learn from Brazil. And that comes to our next important point, that besides a strong moral argument to address cancer outside America, participating in global oncology leads to several learning opportunities that benefit people everywhere around the world. I'll give you some quick examples of that. If you want to look at ethnic diversity and drug effects, where else to study it than in different populations? And pharmacotherapy or pharmacoethnicity can be studied. If you want to look at infectious causes of cancer, which do exist in America and Europe, 4%, 7%, you can go to countries that have it 33% or 16% of the time. And I will remind you about Epstein-Barr virus. The link between Epstein-Barr virus and Burkitt lymphoma was found by studies in Africa, and that helps the whole population of the world, including high-income countries. So there's a huge cross benefit to that. Now, understanding the need and the value of participating in global oncology activities, there's a huge interest in organizations across America to do something about this. I mean, these numbers are not ignorable. All institutions and all organizations are coming on board slowly but surely, if they've not already been actively involved in this already. Recently, in 2018-19, towards the end of the talk, I'll just give you a little bit brief outline of what some institutions across America are doing. NCI and ASCO did a survey of cancer centers across America to look at global oncology activities and interest. 70 NCI designated cancer centers were surveyed and 77 responded. About 50% have a formal global oncology program. About 40% had a program lead, and 87% had funding other than NIH as well. Only 22% had activity in low and middle income countries. Here, global, as I said, is defined by around the world. So that's not enough, but definitely substantial activity going on around the world, around America. And if you look at trainees interested in global oncology by subspecialty, you can look at hematology, surgical oncology, pediatric pathology. It would have been interested if they surveyed non-medical institutions as well. I'm interested in School of Engineering or law or computer sciences. But you can see up to 20% of trainees in different fields are interested in global oncology, and they actually want this to be part of their career. So there's just some surveys. A lot of institutions have up to 80 or 70 global oncology projects ongoing at the time. National Cancer Institute has a whole center for global health to support this. In fact, they came up with a new strategic plan this year, a few months ago, with 4 main goals: to support innovative, impactful research, support global cancer research training, promote science-based global cancer control, and then promote engagement. ASCO has a huge programming on global oncology now, and they've been doing it for many years. AACR also is involved. NCCN is coming up with more and more what we call harmonized guidelines. So how do you take care of cancer when your resources are poor? They've actually come up with a whole set of guidelines for prostate cancer in Latin America recently. So as you can see, there's more and more organizations are investing heavily in global oncology. So totally makes sense that we should also do what we can to alleviate or address this huge burden. And as I try to highlight throughout this presentation, that UW has a lot of strengths and also has a lot of already ongoing global oncology activity, and probably stems from the Wisconsin idea we have, which is our guiding philosophy of outreach efforts in Wisconsin and then expanded throughout the world. Our cancer center's vision clearly states that we want to defeat cancer in Wisconsin and around the world. Our Global Health Institute's vision is equitable and sustainable health for people, animals, ecosystems across Wisconsin and across the world. So our vision for our program in global oncology here would be, we'll be working towards addressing disparities in cancer outcomes. And that'll go across every aspect that I tried to mention, like research, education, outreach, and advocacy across the continuum of cancer care. And a collaborative effort for all schools and institutes of UW, not just the School of Medicine and Public Health, but really engage law, engineering, and all the various many schools that we have and the strengths we have. We'd like to engage faculty across campus. We want to have an outlet for trainees and faculty interested in global oncology. As I showed, more and more people are interested in participating. We encourage and facilitate global oncology research, education, outreach service, and advocacy activities. And the purpose of this group would also be to train leaders in global oncology and build a community within Wisconsin. The initial steps we're at is collating and tracking ongoing activities which we've started. The survey I mentioned from NCI and ASCO, we're doing a second survey. They're going to do it every 2 years. So that'll help us collect all our activities, and we want to bring people together and raise awareness, and that's how all of you can help us and just reach out to each other and to us, and we can start working together. We've already have a lot of sites in low and middle income countries through our global health activities in different departments and schools, and we're maturing them and seeing how we can use them better for cancer control in these countries as well. In the future, we'll have systematic tracking of activities. We'll have a robust program that is really geared towards education, research, and outreach programs of students and trainees and faculties. We'll have regular seminars and symposium, also pilot fundings for research that would really be innovative, and we'll be the leaders in innovation and advancements. If you look at cancer disparities, we'll try to create equitable care within America, but also break down barriers or circumnavigate these barriers in low and middle income countries. That's the goal, that's the vision. These numbers are just not ignorable, and we have to fight it. But of course, we won't reach absolute equity in cancer care around the world. That's not going to happen, but every step towards that is worth striving for. With that, I'll end, and I will take any questions that you guys may have. Definitely feel free to reach out to me by email or tweet if you prefer that. But thank you very much for the opportunity.
Thanks so much, Nabeel. That was really terrific and quite a thorough examination of the challenges ahead. I'm thrilled to see some of the names that are on here that are people from across campus as well as from all around our community that are equally impacted and care about cancer and prevention. and detection. Does anybody have any questions or thoughts that they'd like to share with Nabeel? I guess one of the things I've always wondered about is whether there's any effort or any movement towards having a really unified, collaborative, global program for both funding, but also for research programs. You know, we've got all of these consortiums of research organizations around pediatrics and various single entity oncology issues. Is there any real global organization that has really tried to pull all this together in a way that really allows for multi-country randomized trials and things like that?
So there are, so I guess what I want to say is this: global oncology is not new, and the problem has been there for a while and it's been brewing. So there are organizations that are geared towards cancer control around the world. So UICC is one great example, and a lot of their focus is on registry building and education around cancer and capacity building across the world. Other organizations like WHO, for the first time ever in 2020, came up with the World Cancer Report. They've been doing some cancer care and statistics for a while, but so those would be the two big organizations that are gearing towards capacity building, advocacy, and policy. And then our research organizations, both national and international, are more and more funding global oncology activities as well.
Great. I don't know if you can see the chat, but Sharon Weber agreed with me that that was a great talk, Nabeel. What do you think is the most important, impactful next step to halt the global cancer disparity?
So not screening programs in every country, but I think the most impactful thing is early detection that we can do. But and I might be biased, but my feeling is that we need data. So data to derive policy, data to know what's going on where, and somehow if you give data to people, they figure out ways to make things better. So in my mind, it's research capacity building, infrastructure capacity building around data generation, and then the use of that data to better cancer care.
Thank you very much. Sue Guzman wants to know what companies or institutions are leading the efforts in data collection and analysis at this point.
So I wouldn't say there's a lot of companies or institutions. The couple I mentioned was the UICC and WHO, and I can write that in the chat as well. Sorry. Those are some studies that do registry-based global oncology care, but it's more like the slide I showed is more than just population-based registries. We really need to know a lot of the etiologies, the causes. We need to know the lifespan, the mortality and disabilities, and we need to know outcomes as well. I feel like the biggest gap is in outcomes. We don't know what is the chemotherapy we're providing, is it guideline concordant? Is it effective? What about radiation? What about surgery? Is it safe? How many people? Is the treatment we are giving, is that effective or not? So those are big gaps.
Hi, my name is Rick Anker. I'm a nurse anesthetist, and I do a great deal of work over in Laos. One of the struggles that we have is we just don't have the infrastructure, and anybody that's diagnosed with cancer, they either have to go to China or Thailand in order to be treated, and they just can't afford it. Any suggestions in where we even start there?
Yeah, I did not talk about financing oncology around the world, and I try to touch upon a lot of things as a big overview, but even that light overview of every topic is not enough. So, but financing is definitely a challenge. But there are organizations and institutions that are willing to work with governments to come up with ways to do that. And a lot of it is tax-based things like, tax levies on tobacco products would be an example. The other would be advocating for government priorities. Government priorities have been on trauma and malaria or HIV or whatever unfortunately, to say high-income countries derive, vertical programs rather than health system strengthening initiatives. So those have been some problems that advocacy and policy can help, and data can help with that. Other thing is that the return of investment is pretty significant. A big resource to look at would be the cancer report I mentioned from WHO, and they do this whole financial analysis in which they look at how many dollars if we invest in low and middle countries, and how much GDP around the world will save in the next 10, 20 years, and it's pretty clear that the return of investment is huge. So what I would say is advocacy is what's going to help countries the most. That's going to take time, but in lieu, we can take all these little steps, data or teleproctoring, Project Echo, capacity building, research capacity building. And then we as an institution and individuals can definitely give our intellect and our time, and hopefully the Global Oncology program that we develop will create that outlet for someone like you and others who are interested to actually make a difference and make change.
Terrific. Thank you so much, Nabeel. I was wondering, do you guys have a centralized contact yet for the Campus Global Oncology group that people could go to, or is that still in process?
Yeah, so sorry, I didn't mention that the Global Oncology program is pretty nascent. We're just starting out, but in the future we will have, centralized resources and contact information.
Well, we will be happy to share that with everybody through the Global Health Institute listservs and all those things when you guys are at that stage. But it's been really thrilling to see you already starting to pull people together across campus and bringing in all of your contacts and colleagues from across the globe. And I have nothing but optimism for where you're going to take this over your burgeoning career. So thank you very much for sharing with us, and wish you luck as we continue to work together.
Thank you so much, Dr. Conway. And I really do appreciate comments from everyone. And other people might have logged off, but if I know whoever's listening is interested in global health, and experiences are varied, and there's a lot of wisdom across campus. So I do appreciate any comments that anyone would like to send me. Definitely pay attention.
Great. Well, in the interest of time, I think we'll let everybody go. But thanks again, Nabeel. This was really a terrific talk. And thanks for everybody for joining us. Have a good afternoon and stay safe out there.